Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Beatrice.
Hi, I'm Haley Hoy, professor at the University of Alabama Huntsville and an acute care nurse practitioner and pulmonary at Vanderbilt Medical Center. Welcome to this program titled The Right Fit, Personalizing COPD Device Selection Across a Patient Journey. Joining me today, we're honored to have Rohit Goyal, a physician of pulmonary and critical care at Pulmonary Associates of Fredericksburg in Fredericksburg, Virginia, and Amit Mahajan. He's the medical director of the Interventional Pulmonology and Complex Airways Disease Program at the Inova Health System. And he's also an associate professor at the University of Virginia Medical School in Falls Church, Virginia. Welcome. Before we start, I would like to pause and ask the attendees about the following. How do you personally approach shared decision-making with your patients when it comes to device selection? Do you think there are opportunities to further empower your patients in these discussions? As many of you know, COPD management is evolving. It's personalized, it should be patient-centered, and that's really the standard based on GOLD guidelines. So we're moving from the one-size-fits-all to prescribing something that is specific for that patient. We design care plans around symptoms, comorbidities, preferences, and a patient's lifestyle. So shared decision-making is now emphasized, and we empower patients to be active in their care. So let me level set us a little bit just to ground the discussion for those who aren't in pulmonary all the time. Bronchodilation is the mainstay of pharmaceutical treatment for stable COPD. We have short and long-acting muscarinic antagonists, short and long-acting beta-2 agonists that are administered alone or in combination, and we'll talk more about that, with or without inhaled corticosteroids. Devices, of course, include dry powder inhalers, pressurized metered dose inhalers, soft mist inhalers, and nebulizers. So each of these vary by design, how they're handled, and by inhalation technique. So I'll ask Dr. Goyal, what considerations guide your choice of device for each patient?
Yeah, thank you, Haley. A great question. I think this is a very important question for us pulmonologists, as COPD is our bread and butter. What I tell everybody now is an exciting time for COPD. There's a lot of new therapies, a lot of new advancements. We have endobronchial valves, we have biologics, we still have pulmonary rehab, oxygen, but there's more and more devices, more inhaler options, more nebulizer options. So it does get confusing. So there's a variety of factors. I think when we first come out of training, the stuff you're attending, as your mentors taught you, is kind of what you go by and you have a preferred device. But over time, as you get more clinical experience, you read the data, more data comes out, GOLD guidelines, as you know, keeps evolving. All those things influence me and my decisions, okay? But in the end, we have to take each patient individually and offer the best medicine and device that we think can treat his COPD. So there's not a single inhaler device that suits all patients universally. I think as pulmonologists, we can all agree on that fact, okay? So it's important to match the device with the patient needs. Okay, so GOLD does break down COPD patients into the ABE algorithm. So we have to take into account their symptoms. We use symptom scoring such as MMRC and CAT score to help devise that, exacerbations and hospitalization. So I take that into account. The question is, what device? GOLD does recommend individualizing these patients to their inhaler or their nebulizer based on specific factors. So what are those factors, right? So a study has shown that about 79% of our COPD patients will have at least one physical or cognitive impairment. So we have to screen our patients for these impairments, right? Could it be memory issues? Could it be dementia, osteoarthritis? I think it's very important for our COPD patients to look at their hand. Do they have a tremor? Do they have dexterity issues? All these things are going to impair their ability to use a certain device, right? Neuromuscular disease is a big one, osteoporosis. So looking at those concurrent issues is important. Other things I look at is insurance, right? Cost is a big issue. As we know, some patients cannot afford inhalers. Like I give you an example, my VA patients, I have to tailor them based on certain inhalers, based on the VA requirements. So we need to look into that. I think lifestyle is very important. Some like to travel, some don't. So I think you need to tailor them accordingly. Pick the right type of inhalers. There's different types. Pick the right type of nebulizer, the right type of device.
Bobby, how do the most recent GOLD recommendations help guide our initial and ongoing treatment choices?
No, Haley, that's a great question. I think what we really utilize nowadays, as you stated before, is not just a one size fit all approach. And I think it really is dependent not only on the symptoms of our patients on a regular basis, but really GOLD has moved towards the idea of symptoms, but also the use of exacerbations with regards to how we treat patients. And if you remember before, the GOLD guidelines are based on an A, B, C, D kind of step up position. Now the C and D are actually removed and are replaced with the E, which is really focused on exacerbation. So if we talk about group A is really based on the use of bronchodilator therapy for an MMRC of 0 to 1 or a CAT of less than 10. And we're really looking at just 0 to 1 exacerbations per year, not leading to a hospital admission. So again, those are the kind of data and information we need to hear from our patients on a regular basis. If we look at group B, that's really focusing on a LABA and a LAMA with an MMRC greater than 2 or a CAT greater than 2 with the same number of moderate exacerbations, usually looking from 0 to 1, not including a hospital admission. Now, when we jump up looking at E, this is where things have changed a little bit. Rohit alluded to this earlier, that now we look at from an exacerbation standpoint, greater than 2 exacerbations that are considered moderate or at least one leading to a hospitalization. Okay. Additionally, in those situations, we look at obviously LABA and LAMA therapy, and then you consider LABA and LAMA therapy in addition to ICS therapy if the eosinophils from the blood are greater than 300. So those are significant changes. Now, they don't really make it a huge difference in how we treat people in terms of providing the best care, but it does categorize them a little differently compared to what we had done in the past. Now, I will say, in addition to those recommendations, we have to be able to take that data and continue to follow it on a regular basis, as opposed to treating someone by the GOLD guidelines and saying, we'll see you in a year. Really, what we have to look at is a few things. Sometimes we have to see these patients more often, especially when we're changing their GOLD recommendation in terms of what category they're in, and keep up with them in terms of their symptoms. So we kind of look at a review, assess, and adjust model, where with regards to review, we look at their symptoms in terms of how much dyspnea they're having and looking at their MMRC and CAT score, and then also seeing when they have an exacerbation and honestly keeping track of that so that we see them next time or if they continue to happen, we can make adjustments. The next step is then to assess them, looking at inhaler techniques and non-pharmacological approaches such as pulmonary rehabilitation and self-management education. We want to make patients aware that are they being assessed appropriately both by the physician and themselves. And then we have to escalate. We have to adjust, whether that's escalation or de-escalation, or sometimes switch inhaler device or the type of molecules, meaning that we're saying that a patient qualifies for a type of category, but we have to be able to adjust their medications on a regular basis. And with that comes different devices and different types of techniques. So with the GOLD guidelines, we've taken a step forward since 2023 with regards to how we categorize patients. But again, in order to be really patient-centered and tailored to each patient, we have to make sure we review, assess, and adjust on a regular basis. So also when we talk about GOLD kind of utilization and characterization, it really is looking at what is the right device for that person. So example, as Dr. Goyle had mentioned, we have to look at the patient characteristics with regards to different devices we use. Not only is the patient strong enough to use these different types of devices and do they have the ability to follow the steps, but we have to consider the cognitive capabilities, the physical capabilities, and the inspiratory capabilities in terms of how well these patients are. So for example, if they have chronic medical conditions such as Parkinson's disease, multiple sclerosis, these might be things that make it more challenging to use these devices. And then secondly, we look at education and training for the correct technique. I think education based on the technique and the ability at regular intervals, even though a patient might say they know how to use something, is really important. And a refresher can be just as good as teaching someone for the first time. Last, we kind of look at the idea, are they using these inhalers correctly? So when a patient says, yes, I'm using my inhaler, it really is helpful sometimes to say, okay, well, do you mind showing me how you use this so I can make sure we're not missing any steps? Or having a respiratory therapist who's really focused on just educating and making sure that these are being used correctly. And honestly, the number of steps that are required for using an inhaler are significant. And if they don't have the ability of using those and they don't seem like they have the ability to improve utilization, talking about switching to a nebulizer or something of that nature. And then, I think that these kind of visual checks, talking patients, making sure their inspiratory flow is enough for the device, again, are something that are essential for us to look at in the office, and have a candid conversation with that. If they don't feel as though these are being beneficial and you've witnessed these different issues, then you can have a more informed decision of, again, adjusting after you've assessed to make sure that their treatment plan is going to be tailored directly to their needs.
Great. So let's just pause for a moment to the audience. And when was the last time you really considered a patient's inhaler device, not just their medication, not the drug class, but based on maybe a change in their health status, if they were discharged from the hospital or their daily living situation? Dr. Mahajan, do you have an example of that?
Yeah, it's funny because we have patients come in, they'll talk about their COPD, their emphysema, and we will say, have things changed? Are you feeling better? Are you feeling worse? And I think that it's an evolving, like we talked about, situation that people's lives are changing constantly. The medical kind of status is getting worse, kind of getting better. And I think that what we talk about is not necessarily are you just feeling better, but what things are you doing to make yourself feel better? What things are you doing in your life that are making things more difficult? So, for example, if we talk to our patients in the wintertime, they're not going out as much. They're a little bit, honestly, a little deconditioned because it's cold, at least in the Virginia area. And what we run into is, where are we on that spectrum of you feeling well or you feeling worse? Whereas in the summer, they might say they feel much more well because they're able to get out. And in those cases, they say, look, in the winter, I'm in the house all day. It's not a big deal for me to be able to take nebulizers on a regular basis, as opposed to utilizing my inhalers. But in the summer, they might say, look, I'm able to get out more. I want to be out more. I'd rather take an inhaler with me as long as they're being able to use it appropriately. So I really look at it as our job as physicians, respiratory therapists, nurses, PAs, NPs, really to listen to our patients on a regular basis, because it's very easy just to tailor something to what they were dealing with years ago and not change it. It really is our responsibility to listen to their health status, look at their daily living situations, and make kind of adaptations. I also think we have to remember that patients sometimes, depending on if they're in an E category with gold as well, they might be getting admitted to the hospital more often. And sometimes they get changed on terms of what types of inhalers they're using in the hospital and what they go home on. So again, it's our responsibility that things change. They're always evolving with the patient's medical status. We as physicians and healthcare professionals have to adapt that on a regular basis and keep up with it, as opposed to just saying, well, this is the cookie cutter approach, and actually make it more usable and friendly to our patients.
I think you bring up great points, and especially with gold guidelines. The one thing that sometimes is overlooked in 2023, they added an adherence section for COPD, and they've shown that up to 50% of COPD patients are non-adhering with their medications, and that leads to exacerbations, quality of life, healthcare, COPD readmissions. So it's important to look at that adherence. One of the things we recently just started using are smart inhalers, and it's a device that you put on your inhaler, and it gives us a lot of feedback. We can do remote therapeutic monitoring and see if they're actually using their inhalers. Because when a patient comes to you, if you ask them casually, "Are you using the inhaler?" a lot of times they're going to say yes when they're not using it, right? And you have to employ that. So this is actually data that will come right back to us and can tell us, and it can tell us if they're able to get that inspiratory flow and their ability. And then based on that data, maybe we have to switch them to a different type of inhaler, or maybe switch them to nebulizers.
That's a really good point, Dr. Goyle. What about Dr. Mahajan? Can you talk a little bit about the strategies you use to incorporate your patient's preference when choosing a device? How do you incorporate your patient's input?
Yeah, no, it's a great question, Haley. I think that this is the universal approach nowadays to how do we get to a way we improve compliance, not only by utilization capabilities, meaning physical capabilities, but also insurance is a big part of this, meaning that how do we make these uh, patients more compliant based on the financials. So really, what we talk about is one, first of all, in our office, we discuss this pretty clearly that we're going to find the best option for the patient based on what they're capable of affording and what is going to be not cost limiting for them. The other option is also just talking with them about what has actually helped them in the past or what are they willing to do. And I say that, for example, in someone who says, well, I'd come to a patient and say, we're going to consider trying this new inhaler. And the question is, well, is the cost or the new cost going to be worth the utilization by the patients? If the patient says, look, I've tried this before, it hasn't been useful, and as a result, even if I'm going to get it from the pharmacy and pay for it, I'm not going to use it, we take that into consideration. So the goal is to make sure, one, financially it's sustainable, meaning that even if it is good for them, we want them to be able to afford it. And sometimes that does come with support from our hospital or other websites or other institutions. The second thing we ask them typically is, if you have to pay for these different types of inhalers, is it going to prevent you from being able to utilize other medications that you need? And obviously, if that is the situation, we have to make a concession there. We have to make a change to what we're doing so they don't lose some of their own health care. And then finally, at the end of the day, we talk about the idea that physically and mentally, are you going to be able to handle these medications? There are sometimes where asking a patient to take 3 or 4 different medications for the same medical issue, and it just becomes overwhelming. So there are patients who I've talked to who said, look, I've tried using these inhalers. I know they're better for me, but I just can't physically, use them effectively. And it's not their fault. There are a lot of steps to be using an inhaler appropriately. And they say, is there something easier? For example, when I go to the hospital and get admitted, they just give me nebulizers. Couldn't I have that? And that's an option. And I think that as physicians, guidelines are great, don't get me wrong, but we also have to be able to tailor those guidelines and those recommendations to our patients' capabilities and limitations as well.
You've mentioned cost, and I have to say, as a nurse practitioner, particularly at the VA, many times we will use nebulized medications now that you mention it for cost reasons and for ease of administration. And another time is with long term care. If I'm rounding in a sniff, if you will, the patients have the time and it reduces some of the caregiver burden to use the nebulizer. But sometimes there's an assumption that those are only for elderly people or people who are disabled. What are your thoughts on that?
Yeah, I think that's a great point, and we give the example of a VA patient, but you can also just look at other things like private insurance, Medicare versus Medicaid. But, with my VA patients, I sometimes struggle because they can use maybe one type of DPI, one of the soft mist inhalers, right? And they may not like the powder, but there's a very short list that's approved. And surprisingly, I can't get them on a triple inhaler, a LABA LAMA with an ICS. So usually they're on dual therapy. And then they're subjected to a powder, which they don't like. They may develop thrush or sore throat. So yeah, I do employ nebulizers and long acting nebulizers. And a lot of times, not just for, our VA patients, cost is much more affordable for those patients. And like I said, 79% of these patients are going to have some sort of other impairment that probably prevents them to maybe using that type of inhaler properly, or just needs more education and reinforcement.
Speaking of that, Rohit, tell me how you incorporate or depend on your respiratory therapist and pharmacist as far as device education and continuity of device education.
Yeah, yeah. So we employ different strategies. We have a private clinic. I'm a little bit different with Bobby. But I like to do a team approach. So my nurses are a great place to have them educate and see if they pick up something. And sometimes they may mention something or write it on a note, say, "Hey, they're not using the inhaler properly." I think using a respiratory therapist is one of the best resources you can have. In our PFT lab, patients are spending anywhere between 15 minutes to an hour with them. So our respiratory therapists are counseling them, and especially if they're having a bronchodilator challenge, they're using the inhaler. Are they using it properly? And then a lot of times they'll write something or send me a message and say, hey, maybe we need to consider switching them. So it's a team approach, pulmonary rehab. And I think the hospitalist respiratory therapists are one of the best resources because they're sitting in the hospital all day. So I try to implore you, encourage your respiratory therapist to educate them and really find out the intricacies of what they can do.
So you mentioned a private practice. Do you have a nebulizer in your office?
Yes, yes. So we actually started doing this like 2 years ago. We've been it was funny before we would have to like prescribe a nebulizer machine and then tell them to either go to a DME company or their pharmacy. Back if they don't have it and there's a backlog, then they may not get that nebulizer for some weeks, and especially if they've just come out of the hospital, they could flare up again. So we started working with our local DME companies to supply them in our office. So we actually hand them the nebulizer machine, and a lot of times we have samples of the solution so they can start that day of. Then we go ahead and build their insurance through the DME company, and it's worked out great. I don't know why you didn't think about this early, but I implore pretty much most practices to have that ready in your hand and ready to go, and then you can also educate them how to use it.
Great. And then, Dr. Goyle, can you speak to, for people who aren't in pulmonary all the time, there may be the assumption that your nebulized options are limited. Can you speak to the availability of those medications in nebulized form?
Yeah. I mean, like I said, there's more and more nebulized, and through my career, I've started identifying these patients. I feel like I'm using nebulizers more than I'm using the inhalers. I was, they've always quoted studies saying they've never been able to prove that nebulizers are better than inhalers. And so that's one thing. But the one thing, as you guys know, when you're doing a controlled trial, right, these patients are being monitored and making sure they use their inhaler on a daily or twice a day. They're showing them technique. So it's not real life, right? Real life patients are busy. They may not really understand how to do it. Like Bobby said, they were in the hospital, they're flared up, their inspiratory flow and ability to take a deep breath after the hospitalization and discharge is a reality. These patients get deconditioned, they're not walking, they lose weight, the respiratory muscles get weaker. So I use nebulizers usually during exacerbations, through the hospitalizations, and then keep them on afterwards, and then may transition back to their inhalers, or may, if they do much better, keep them on long-acting nebulizers. So I think you got to look at everything. And now that we have more options for the long-acting nebulizers, I think it's really, really good. And I think it's something that we have to really identify in our patients.
Anything to add, Dr. Mahajan?
Yeah, I would echo pretty much everything that Rohit said, and I would even add, two aspects is that the physician-patient relationship, it truly is a relationship. So we don't want to be in a situation where patients feel kind of guilty, or they don't want to come out and tell their physician that they are not using their inhalers, or they're having trouble using their inhalers. So I think it should be kind of a proactive conversation, and from the physician standpoint, to actually say, look, it's not uncommon that people have trouble using inhalers. Are you having any trouble using them? And do you think they're really effective for you right now based on the different logistics that are necessary to use them? And then be open to listening and then making different changes as necessary. And then the second part of that is, I think that our focus obviously on inhalers and making sure that patients are as functional as possible, but then say, look, this patient might be using their inhaler appropriately. They might be doing everything they can to improve their shortness of breath and functionality. And then taking the next step to saying, okay, well, you've mastered these inhalers. What are the next possibilities? Do we get you into pulmonary rehab? Do we try and strengthen your inspiratory muscles so that you are feeling even better now that you've mastered the inhaler? So it doesn't have to be an all or none with regards to is it working or not. It can be a discussion about what is working that's candid, and then moving forward into the therapeutic kind of realm of what's the next thing we can do for you to improve your quality of life.
Absolutely. And I love what you said, Dr. Mahajan, about pulmonary rehab. Those professionals can help us reinforce device therapy. Dr. Goyle, you see lots of patients in your day in clinic. Do you ever have perhaps not the patient struggling, but the caregiver with device issues?
Yeah, I mean, caregivers, family, it's important, and especially when they're in the room with you. Like I stated earlier, usually if you ask the patient are they using the inhaler, they're going to say yes sometimes when they're not. But then the caregiver and the family can give us a lot of input there, and we can use them as a resource. And sometimes they know the proper technique. I've had patients where their wife or their caretaker knows how to use the inhaler or nebulizer. before we've started them on them, so then I can use them as a resource to continue to follow them at home. But I think imploring them for sure as a resource can be helpful. It's also they to give them some sort of responsibility to have the patient remind them to use it and make sure that they're more adherent with their therapy.
Great, thank you.
So yeah, Rohit, I completely agree. I think that having a caregiver in the room with you is essential to getting the full story. And a lot of that is because we're seeing them a small snippet of time in that office visit. But your caregiver, whether it's family members or friends, are seeing them when they're honestly at their worst, when they're not sitting in the clinic. And it can be a delicate topic or a delicate subject because again, the caregiver doesn't want to be overstepping their grounds or contradicting what the patient is saying. So, in a lot of times when I'm talking to the patient, out of my side, I am also looking at that caregiver who's sitting next to them to get kind of not only facial cues, but also engage them in that conversation and saying, look, sometimes it is hard for us as a physician and the patient to see things and recognize things that we're so used to kind of compensating for. And I'll ask that, that caregiver, do you see anything that we're missing, or do you notice anything that we might not be understanding is going on a regular basis, but you might be, more privy to that information. And very commonly, it's they open up and say, look, I know he's been feeling good today, but over the last couple of weeks, he's been really short of breath. So there might be something that we're missing. That's very important. And I think the second thing is we kind of forget about the idea of caretaker fatigue. Caregiver fatigue is very important in the sense that we're trying to take care of family members or friends, and that really weighs on them. So, if it is challenging to use a device like an inhaler and make sure it's using it correctly, it might come to the point where the caregiver says, look, it's just too complicated. I'm not going to use it. In those senses, when a physician can notice that or detect, signs of that, it might be easier than to move them to something that is a little bit less, physician, patient, and caregiver intensive, like a nebulizer, just to simplify the regimen and take a little bit of burden off of the caretaker as well.
Yeah, Bobby, you bring an excellent point. About recognizing. Sometimes as clinicians we don't recognize, but a lot of times the patient isn't going to recognize what works for him. The caretaker is looking. I've had examples where family members or caretakers are in the hospital when they're flaring up, and they notice that once you switch them to the nebulizers, they're doing better. But then you see them in the clinic, the patient forgets this. They've been through so much. They don't say, hey, by the way, can we switch? They forget that. So a lot of times the caretakers, they want to be like, hey, that nebulizer solution or whatever they use in the hospital really worked. So really imploring them, especially after hospitalizations, and then adjusting their treatment would be very helpful. So being able to recognize using all those help from the family is important.
These are excellent points. Dr. Goyle, so we mostly focus the device selection in the office, but it's important to remember, I think, that the choice of inhaler when we discharge someone from the hospital can also affect their adherence, their continuity of care, and ultimately risk of readmission. What strategies have you employed that might impact that?
Yeah, I mean, that's been a difficult hurdle, as probably all of us have to deal with this with hospitalizations. I mean, usually when you're doing your discharge paperwork, maybe the primary hospitalist is doing it, and it's very easy for them to start them back on their normal inhalers and just go through a checklist of medications and then discharge them, and then maybe giving them some prednisone. But I think that's where we have to educate and teach the primary team, the hospitalists, that what, the inhaler is probably not going to be enough now. They just flared up. They're not perfect still. So that's where you have to see if they have a nebulizer at home, have the respiratory therapist teach them that day before they leave on how to use it, and then have them start using it right away, right? 2 to 3 times a day until they see their pulmonologist. We try to get these patients in the office within 2 weeks, but we're all very busy, so it doesn't happen sometimes. So there has to be proper education to help stop those readmissions.
So I would be interested in any mechanisms that you guys have used to break the cycle of patients ending up back in the hospital or for inadequate treatment. Dr. Mahajan, do you have any words of advice on that?
Yeah, I mean, like you said, Haley, like you said, Roy, I mean, the transition from the inpatient world to the outpatient world is incredibly complicated, not only because, again, circumstances might have changed in terms of patient health quality, but it's just a huge step when someone could be critically ill and then getting back home. So we implement a few things. The main thing we'd use, and as you both touched on, in the hospital before discharge, we try and get the patients back on to whatever they're going to be using at home. Whether it's a new medication or an older medication, on the day prior to discharge, we try and say, look, this is the medication they're going home on. Let's start using this in the hospital. Is not always as practical as possible. Sometimes, the hospitalist doesn't even know the patient's going home that day. But it's one of those situations that we want to be, kind of preemptive about this. Like you guys both said, the respiratory therapists are incredibly valuable in going through education before the patient goes home. And also just sitting with them at the bedside while they're in the hospital, preparing them for that transition and answering any questions. And then finally, which I think has become, a kind of a national standard, whether it's immediate follow-up in the office kind of world within 2 to 3 days after discharge to check on how the patient's doing and to make sure they don't have any questions about medications is ideal. But again, it's not very practical in some ways. Getting patients into the clinic is challenging, and sometimes, especially if it's on a Thursday or Friday, the discharge, you don't have the ability to get them in within 48 to 72 hours. So what we typically will try and do is have one of our nurse practitioners or physician assistants at least call the patient on day 2 to 3, check on how they're doing. Are they having any issues with using their new medications? Did they have any trouble getting their medications? And then finally, do they feel like they're on the upswing or feel, their shortness of breath is improving? And if it isn't, that is a red flag to say, look, why don't we get you into the clinic right away as opposed to having to go to the ER, 3 days from now and having an exacerbation.
Yeah, I think those are great points, Bobby. Sometimes getting the patient in the clinic could be from our standpoint, but a lot of times the patient doesn't want to come to the clinic because they just came out of the hospital. They may not have a ride, and then, like you said, we're in Virginia in the winter. We've had some bad snowstorms. The last thing you want them is going out in the cold and then they're flaring up again. So I think that's a great idea. Give them a call, reviewing the medications they're on, and then adjusting it. Even though the hospitalist or whoever's discharging them, sometimes they forget to write that nebulizer machine or forget to write that prescription. So being able to catch them on at least day 2 and seeing if they need those prescriptions, and then a family member or caretaker can go pick it up, is a great help for these patients to stop them from going back to the hospital.
Yeah, and along those lines, we're very obviously pulmonary centric, but making a simple call to their primary care doctor when they're being discharged and saying, look, just FYI, this patient is going to be going home. We're going to try and get to them, but do you have any problems seeing them in 24 to 48 hours just as a follow up? I think that kind of communication between physicians is huge. And again, it provides a safe landing space for the patient, even if it isn't with the general pulmonologist. It at least is having someone who knows them well following up with them, and they can also answer a number of those questions which may be necessary, especially the transition that might have changed some of those medications or devices from the hospital back to the outpatient world as well.
Those are all great points. Just to conclude with 2 or 3 points, if I'm hearing you both correctly, is once we have the drug classes, we need to really consider the patient's input and not just give lip service to patient-centered care when we choose the device. And then we need to teach them really well, preferably ourselves or to use other healthcare professionals, and then have them show us how they're using their device and make that an open, honest conversation at every visit. I want to thank you both for this excellent discussion, and thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation